The date is the 26th of January 2018. This is a lecture for the Sports and Exercise Medicine online review course on sportmedschool.com. My name is Dr. Howard Chen. I'm a clinical instructor and lecturer at the University of Toronto. I've been asked to give the Sports and Exercise Medicine hand review lecture. I wish to disclose that I've previously received an honorarium from Sanofi Canada. There are no potential conflicts of interest for this program, and all efforts have been made to mitigate potential bias and provide currently available data. On slide 3, you'll be seeing the list of conditions that we will be reviewing today. They will be divided into 3 sections. First, there will be soft tissue injuries involving tendon, muscles, and ligaments. There will also be fractures and dislocations involving bones and joints. And there will be a third group involving miscellaneous conditions of the hand or regional or generalized symptoms that present with hand symptoms. The first condition we'll be reviewing today is jersey finger, which is the avulsion of the flexor digitorum profundus tendon at the distal phalanx insertion. There is proximal retraction of the FDP tendon, and 75% of cases involve the fourth digit. The condition usually results in rugby or football when a player is trying to tackle an opposing player by grabbing and pulling on their jersey. This results in a forced extension of a flexed DIP joint against active FDP contraction. Differential diagnosis would include distal phalangeal fractures or intra-articular fractures, as well as volar plate injury and injury more proximally along the FDP tendon or at the musculotendinous junction. Physical findings would include pain, swelling, and bruising in the volar aspect of the DIP joint. There's usually slight extension at rest and flexion leg with inability to actively flex the DIP joint. The hallmark finding would be lack of isolated FDP contraction with neutralization of the flexor digitorum superficialis contraction. Jersey finger is characterized by the amount of FDP retraction. Type 1 would be tendon retraction to the palm. Type 2 would be retraction to the PIP joint. Type 3 would result in avulsion fracture of the fragment attached to the FDP, and it would be tethered at the A4 pulley. And type 3B is avulsion fracture, but the FDP tendon is also avulsed from the bone fragment. Imaging would include x-rays with a true lateral view to assess for avulsion bone fragment location with retraction. Management usually requires urgent hand surgeon referral, as we are trying to preserve the vinculae blood supply for the tenosynovium. This will provide low friction repair for unrestricted tendon glide. If the bone fragment is large enough, then there is open reduction internal fixation, or if there is no bone fragment or it is quite small, then this will require direct tendon repair. Hand therapy is provided with early motion post-op to prevent stiffness, and tendon healing generally requires 2 to 3 months for full recovery. The second condition we will discuss today is mallet finger, which is a flexion deformity of the DIP joint with disruption of the extensor mechanism. If this is left untreated, then this can lead to chronic extensor leg and delayed onset swan neck deformity. This is also called drop or baseball finger. The mechanism of injury is often a result of direct end-on impact to an extended finger or forced flexion during active attempted extension. Findings would include swelling, tenderness, and bruising on the dorsal base of the proximal phalanx, extension leg, and inability to actively extend the DIP joint. X-rays will provide evidence for possible avulsion fracture, and MSK ultrasound may provide some assessment of tendon injury. It is important to differentiate mallet finger from jersey finger, as jersey finger requires urgent surgical referral. Mallet finger can be treated with splinting. It's splinted in hyperextension at the DIP joint with aluminum splint, or a stack splint for an uninterrupted period for up to 6 to 12 weeks. This is followed by 4 weeks of night splinting. We try to discourage repeated removal of the splint, as this increases risk of recurrence of mallet finger, but you have to protect against skin moisture and maceration. A surgical referral may be required if the bony avulsion fragment is more than 1/3 of the articular surface, or if reduction is inadequate. The third condition we will review is trigger finger or stenosing tenosynovitis. This is caused by inflammation of the flexor tendon sheath. It is more common in individuals with diabetes, rheumatoid arthritis, and amyloidosis. Again, the fourth finger is most commonly involved. The mechanism is entrapment of the flexor tendon at the level of the A1 pulley overlying the MCP joints. With prolonged inflammation, there is fibrocartilaginous metaplasia of tendon and pulley, which results in the pathology and triggering. Differential diagnosis would include pulley injuries, osteoarthritis, Dupuytren's contracture, and sesamoid injuries. Exam usually indicates clicking at the distal palm near the A1 pulley with flexion and extension, or if the condition is severe, the finger may be locked in flexed position. There's usually tenderness at the A1 pulley on palpation, and there may be a palpable bump. MSK ultrasound would show tenosynovitis and stenosis, and possibly triggering on dynamic ultrasound. Management usually involves use of night splint, activity modification, NSAIDs, corticosteroid injections in the flexor tendon sheath, and if all else fails, surgical release of the A1 pulley and one slip of the flexor digitorum superficialis, which is usually the ulnar slip. With discussions around pulleys in trigger finger, this will lead us to pulley injuries, which is our fourth topic. They provide stabilization and support of the flexor tendons in the palm and fingers. The A2 and A4 pulleys are critical to bowstring, to prevent bowstring, and are most biomechanically important. The A1, A3, and A5 overlie the metacarpophalangeal joint, PIP joint, and DIP joint, respectively, and are originating from the palmar plate. The A1 pulley is most commonly involved in trigger finger. There are also 3 cruciate pulleys which function to prevent sheath collapse and expansion during digital motion. They also facilitate approximation of the annular pulleys during flexion. The injuries usually occur in baseball pitchers, rock climbers, and Japanese tendo. The mechanism is a result of hyperextension of the DIP joint with concurrent proximal IP joint flexion. There is tearing or rupture of the pulley, resulting in bowstring of the flexor tendon. The patient would present with acute onset digital pain and possibly deformity with attempted flexion of the digit. The patient would also present with loss of strength, usually in the third digit. Investigations would include soft tissue imaging with MSK ultrasound and MRI. Management is exclusively non-surgical with tape or bracing for 4 to 6 weeks and a gradual return to competition with excellent results. An example of the taping is seen in the image slide number 11. If bowstring occurs and is disruptive or bothersome, then late pulley reconstruction may be considered. The fifth condition is ulnar collateral injury of the thumb at the metacarpal phalangeal joint. This results from acute sprain or tear of the ulnar collateral ligament with forced radial deviation. It is seen in skiers and football players and is also called skier's or gamekeeper's thumb. Differential diagnosis would include avulsion fracture, adductor pollicis strain or tear, pulley injuries, volar plate injuries, or sesamoid injuries. On exam, increased valgus laxity and pain is noted. There is actually decreased pain with a grade 3 sprain, but there is more instability. The joint stability is checked on valgus stress of the MCP joint at 0 and 30 degrees flexion. If valgus laxity is noted on flexion, then there is damage to the ulnar collateral ligament alone. But if there is laxity on extension, then this indicates complete tear and likely involves the accessory ulnar collateral ligament as well and the volar plate. Imaging would include AP, lateral, oblique, and stress radiographs. The MCP joint is stable if there is less than 15 degrees valgus laxity at 0 and 30 degrees flexion, and there is a firm endpoint. Management would include a thumb spica splint or cast with unrestricted movement of the IP joints. There is no agreement on return to play without surgical repair. Early return is less likely with increased skill required of hands. Surgical repair is recommended if there is greater than 35 degrees of opening or greater than 20 degrees side-to-side variation, or a Stener's lesion is present. Stener lesions occur when there is a high-grade or complete ulnar collateral ligament tear of the thumb at the MCP joint. The position of the adductor pollicis aponeurosis blocks apposition of the UCL ligament ends and prevents anatomical healing. Differential diagnosis would include UCL avulsion fracture, adductor pollicis injury, and volar plate injury. On examination, there is a possible palpable mass at the ulnar border of the thumb at the first MCP joint. X-rays, ultrasounds, and MRI may be used to assess for avulsion and adductor aponeurosis interposition between the UCL fragments. Operative treatments provided for unstable and complete tears. Timing of the surgery is variable depending on the stability of the joint and also the surgeon. There is excellent results with suture anchor repair, and return to play may be possible at 7 weeks for skilled position players and 4 weeks for non-skilled position players. Slide 13 provides an image for the mechanism of injury for UCL sprain, and slide 15 provides graphic detail for adductor aponeurosis interposition between the two ends of the UCL ligament. We have completed the conditions that are listed in the soft tissue injuries section of the lecture, and we'll now move on to bone and joint injuries. We'll start with a Bennett fracture. A Bennett fracture is an unstable oblique intra-articular fracture dislocation involving the first CMC joint and is located at the metacarpal base. This results in shortening and deformity. 80% of thumb fractures involve the metacarpal base, and Bennett fractures are the most common variant. Complications would include non-union, instability, and traumatic osteoarthritis. The mechanism of injury results from an axial load and a deduction force on partially flexed thumb. The proximal palmar fragment is stabilized by the strong volar oblique ligament and is held stable. The larger distal fragment is displaced dorsally and radially by traction from the abductor pollicis longus tendon. Differential diagnosis would include Rolando fracture, extraarticular metacarpal fracture, UCL ligament injury, volar plate injury. Rolando fractures are less common and more complicated and severe. They result from comminution of the larger dorsal fragment into a Y or T-shaped fracture. On an exam, there will be deformity and shortening of the thumb. X-rays will indicate dorsal radial displacement of the larger distal fragment by the APL and adduction, adduction, and supination of the shaft by the adductor pollicis. Imaging would include X-rays including the AP, lateral, obliques, and hyperpronated thumb view. Management will include placing the patient in a thumb spica splint and referral to orthopedics for closed reduction and immobilization if undisplaced. If the fracture fragment is small, then it will require percutaneous pinning. But if there's a large fragment, then can proceed to ORIF. Boxer's fracture is the next injury, and this is usually a result of an acute angulated metacarpal neck fracture, most commonly involving the fifth metacarpal. Complications can include mal and non-union of the fracture, traumatic osteoarthritis, malalignment and rotation, and avascular necrosis. The mechanism is a direct blow to a knuckle from punching a wall or hitting a person. Differential diagnosis would include other metacarpal fractures and MCPJ injuries. On physical exam, there will be a loss of prominence of the metacarpal head. There usually is a mild loss of range of motion of the MCPJ. On physical exam, we must evaluate for shortening, angulation, and malrotation. You can evaluate the cascade of fingers with flex fingers. Normal position of the fingers should converge and point to the scaphoid. You should look for loss of alignment, scissoring, and crossing of the fingers. X-rays will indicate neck angulation, and cast immobilization is performed if the fracture is stable with no rotation deformity and acceptable angulation and shortening. Acceptable angulation varies depending on the digit, and there is less acceptable deviation as you proceed from the fifth digit to the second digit. Slide 17 provides acceptable angulation starting at 40 degrees in the fifth digit and proceeding to 10 degrees in the second digit. Referral to orthopedics or a hand surgeon is preferred if there's persistent angulation, scissoring, or shortening. Fractures of the second and third digit often require open reduction, internal fixation, or pinning to ensure proper alignment, rotation, and angulation. The ninth condition is tuft injuries or fractures. These are fractures of the most distal portion of the distal phalanx. They're often comminuted but considered stable. There's a high incidence of associated soft tissue injuries to the nail or nail bed. The mechanism is often a crush or shear injury. Differential will include shaft and intra-articular fractures, soft tissue injuries and lacerations to the nail and nail bed, and subungual hematoma. On exam, you'll see swelling, discoloration, bruising, pain and tenderness to the distal tip of the phalanx and nail. The usual x-rays of AP lateral oblique are ordered to assess the degree of fracture and its stability. Management usually involves soft tissue repair of the nail bed and splinting and extension for 2 to 3 weeks. Use of stack or dorsal aluminum splints to immobilize the DIP joint only. This will minimize stiffness and loss of range of motion in the finger. We'll move on to joint dislocations and start with volar plate injuries. The volar plate is a fibrocartilaginous thickening of the volar joint capsule of the IP and metacarpal phalangeal joints. It provides protection and stabilization and resists hyperextension. The volar plates are disrupted in dislocations and hyperextension injuries. Differential would include intra-articular fracture, dislocation, and sprains of the IP and MCP joints. There will be pain, swelling, and deformity of the joint. In complex dislocations, one will often see skin dimpling. In imaging, you should request true laterals as well as AP and obliques for detection of intra-articular avulsion or chip fractures. Joint space widening may indicate interposition of volar plate in the joint. The management involves reduction of the dislocation. Prior to reduction, digital neurovascular status should be assessed. Sometimes anesthesia is required for prolonged dislocations and significant muscle spasm. The dislocations are classified into simple, which do not involve interposition of tissue in the joint and can be treated with closed reduction, versus complex dislocations which have interposition of volar plate or sesamoids in the joint and may require open reduction. If the dislocation is difficult to reduce, or if there's a resistance to full pain-free range of motion post-reduction, then possible surgical reduction is required. PIP joint dislocations are the most common finger dislocations and can be open or closed. They're usually dislocated dorsally and involve the middle phalanx dislocated dorsally on the proximal phalanx. Volar dislocation is possible but much less common. This usually results in disruption or injury to the volar plate. DIP joint dislocations are rare and treated with inline longitudinal traction and extension splint for 2 weeks. PIP joint dislocations usually result from hyperextension or axial load injuries. Differential will include intra-articular fracture, dislocation, or sprain of the IP joint. The investigations and management would be similar to volar plate injuries, as discussed before. Of note, if the PIP joint is stable post-reduction, then buddy splinting is sufficient for 3 to 4 days. Otherwise, the PIP joint is splinted at 30 degrees flexion for 2 weeks, but with active motion for 5 minutes 4 times a day. The majority of surgeons will recommend immediate protected return to play, but there is disagreement on unprotected return to play, with about 40% suggesting after 4 to 8 weeks. MCPJ dislocations are slightly different, as the volar plates are structurally modified. They are attached down to the transverse metacarpal ligament, which stabilizes the metacarpal heads and prevents splaying. They also have connections to the periarticular surface of the proximal phalanx via the check rein ligaments. Sagittal bands also connect the extensor digitorum tendon and extensor expansion. Connect to the extensor digitorum tendon and extensor expansion and help stabilize the volar plate over the metacarpal heads. mechanism usually results from hyperextension injury, resulting in dorsal dislocation of the proximal phalanx and buttonholing of the metacarpal head between the intrinsic hand muscles and the flexor pollicis longus tendon. In complex dislocations, the volar plate or sesamoids will interpose in the joint. Differential diagnosis would include fractures around the joint and Kaplan lesions, which are rare and most common in the index finger, which result in an irreducible complex dorsal dislocation as the metacarpal head buttonholes into the palm. The reduction of the metacarpal phalangeal joint dislocations is different than the other IP joint dislocations, than the PIP joint dislocations. Direct pressure is applied to the proximal phalanx with the wrist held in flexion to reduce tension in the intrinsic and extrinsic flexors. You want to avoid longitudinal traction and hyperextension at the metacarpal phalangeal joint, as this may cause interposition of the volar plate. Complex dislocations usually require open reduction. The joint is generally stable post-reduction and is placed in a plaster splint with the MCPJ in flexion for 10 to 14 days, followed by early range of motion. The next condition is first CMCJ osteoarthritis. This is a traumatic or degenerative osteoarthritis of the first carpal metacarpal joint of the hand at the base of the thumb. It's secondary to previous trauma or repetitive use or injury. Differential diagnosis would include de Quervain, sinusonovitis, and radial carpal injury. There is pain with use, and the patients will often note an axial compression, that in axial compression and movement, they may notice a grinding sensation. The deformity of the hand is described as a adducted stance with a knob at the base of the thumb, and adduction of the metacarpal and hyperextension of the MCPJ. Assessment of the joint degeneration and deformity can be accomplished with x-rays, the usual x-ray views. Management involves pain management with acetaminophen, anti-inflammatories, both topical and oral, as well as intra-articular corticosteroid injections. Joint stabilization can be provided with splints, which are static or dynamic, and soft tissue treatments can be provided by a physiotherapist or hand therapist. If these conservative measures don't help, then referral can be made to a hand surgeon.